Hi everyone, welcome to the Wound Assessment and Care lecture. This is the last of the 3 series of lectures on the integumentary module. Please use the study worksheet to take notes. Key terms are in red text, and a downloadable PowerPoint is also available in the Canvas page below the lecture link. The objectives of this lecture include apply the nursing process to clients with impaired skin integrity or risk for impaired skin integrity and provide appropriate nursing interventions aimed at maintaining skin integrity. Accurately assess and document the condition of wounds, including wound staging. Identify signs and symptoms of wound infection and pain. Implement appropriate dressing changes for different kinds of wounds. Apply hot and cold therapy effectively and safely. The nursing process includes assessment, diagnosis, planning, implementation, and evaluation. Let's take a minute and look at the scenario that we will be using for this lecture. Teresa Walker, 79-year-old female, suffered a stroke last year and is living with and cared for by her daughter. Patient has decreased mobility, weakness, and increased incontinence. Per daughter, she recently developed an open wound on her lower back, which is red and painful. The assessment part of the nursing process includes obtaining a complete nursing history from the patient, including cardiovascular, respiratory, GI, GU, musculoskeletal, endocrine, hematologic, and cancer history. It also includes doing a skin assessment, checking the appearance of the skin, any recent changes, activity and mobility, nutrition, pain, elimination, and assessing risk. Assessment also includes prevention, assessing at-risk patients, cleansing the skin routinely, maintaining higher humidity, use moisturizers, protecting skin from moisture, minimize skin injury from friction or shearing, proper positioning, turning and transferring, appropriate support surfaces, nutritional supplements, and improving mobility and activity. The next part of the assessment would include the actual wound assessment. This includes the anatomical location, tissue type and damage, staging if it's a pressure injury, exudate, odor, wound size, wound edges and peri-wound, infection, pain, and documentation. The most common risk assessment tools used to measure the risk of pressure injuries include the Braden scale, the push tool, and the Norton scale. Waterlow scale and Jackson-Cuban are also used to measure the risk of pressure injuries. After obtaining a complete history of the patient and assessing risks, the next step would be to identify the anatomical location of the wound, which is very important in determining the etiology of the wound. A wound on the bony prominence could indicate pressure. A wound in the skin folds could indicate moisture or friction. Wounds on the toes indicate friction, circulatory problems. Wounds on the bottom of the foot could indicate diabetic ulcers or pressure. A wound on the shin or calf could indicate trauma or circulatory problems. The next step would be to assess the tissue type in the wound. There are different types of tissues. We have necrotic tissue, epithelial tissue, granulation tissue, hypergranulation, muscle, tendon, fascia, and bone. The next step would be to assess any damage to the tissue. For example, denuded, loss of epidermis caused by chemical factors such as urine, feces, or other bodily fluids. Excoriation, linear loss to the epidermis caused by mechanical factors such as scratching or rubbing. Erosion, loss of superficial epidermis due to moisture caused by infection, irritation, or temperature imbalance. Maceration, softening and breaking down of the skin due to prolonged exposure to moisture. Tissue damage is also assessed by the depth of tissue loss. Is the tissue loss partial thickness or is it full thickness? Partial thickness is damage to the epidermis, no subcutaneous tissue exposed, usually less than 0.2 centimeters. Full thickness tissue loss extends to the subcutaneous tissue and below. If the wound is a pressure injury, then staging would be the next step. Is it a stage 1? Intact skin, local non-blanchable redness or very bony prominence. Stage 2. Partial thickness dermis loss, shallow open wound with red-pink wound bed, no slough present. Or it can be an intact open ruptured serum-filled blister. Stage 3. Full thickness tissue loss. Subcutaneous tissue may be visible, but no bone or tendon is visible. Slough may be present and may have undermining and tunneling. Stage 4. Full thickness tissue loss. Subcutaneous fat may be visible. Exposed bone, tendon, and muscle. Slough may be present on some parts and often includes undermining and tunneling. Unstageable. Full thickness tissue loss. Slough or eschar obscures the wound base and makes it difficult to determine the stage of the wound. Often includes undermining and tunneling. Deep tissue injury. Purple maroon, localized area of discoloration, intact skin or blood-filled blister, usually firm and boggy and warmer in color than compared to the adjacent tissue. The next step would be to measure exudate. Exudate could be serous, clear watery, serous portion of blood from serous membranes. It can be sanguineous, red blood cells, looks like blood, bright red, indicative of fresh bleeding, dark red, indicative of older bleeding. Serosanguinous, a mixture of serum and red blood cells, light pink to blood tinged. Purulent, consists of white blood cells, liquefied dead tissue debris, both dead and live bacteria, thick, musty, foul odor, and dark yellow green. The amount of the exudate should also be measured. The amount of the drainage can be scant, wound tissue moist, no exudate, small, wound moist throughout, drainage on 25% of the dressing, moderate, drainage on about 30% to 60% of the dressing, large or copious, wound tissues are saturated, drainage on more than 60% to 75% of the dressings. In some cases, dressings are weighed to determine the exact amount of drainage. The next step would be to assess for any odor in the wound. If kept clean, wounds usually do not have any odor. Terminology used to describe wound odor include strong, foul, pungent, fecal, musty, sweet. Causes for wound odor include bacteria, dead tissue, saturation, and contamination. The next step would be to measure the wound. The purpose of measuring a wound is to quantify and measure the progression of the wound. Key points are make sure you have adequate lighting, clean the wound first, use the same anatomical position each time, hold back sagging edges, include the positioning in the documentation. Consistency is the key. A wound is measured with the linear technique, where we measure the length, width, and depth, edge to edge, measured in centimeters. We use the face of a clock, where 12 points to the head and 6 points to the feet. The depth, the deepest portion of the wound. Then we measure for any undermining or tunneling. These are the steps for measuring wounds. We always use a clock face, where 12 points towards the head and 6 towards the feet. Step 1 is measuring the length, edge to edge of the wound. Step 2 is measuring the width, edge to edge. Step 3 is the measurement of the depth, the deepest part of the wound. Step 4 is measuring for any undermining. Step 5 is measuring any tunneling. The next step would be to assess the edges and the peri-wound. It's important to inspect and palpate. Assess tissue minimum of 4 centimeters from the edge, the margin of the wound. Palpate for moisture, temperature, turgor, pulses, and any mobility. Assess the color, induration, warmth, and edema, and assess for pain. Wound assessment also includes assessing for signs of infection and assessing pain. When assessing infection, the symptoms can be local or systemic. Classic symptoms include redness, pain, heat, swelling. Other symptoms include delayed healing, abnormal odor, friable granulation tissue, edema, induration, increased serous exudate, change in color, absent or abnormal granulation tissue. Pain assessment is very important as well. Pain is what a patient says it is. There are different types of pain. We have acute, neuropathic, and mixed category. The PQRST of pain can be used to assess the level of pain the patient has. What provokes the pain? What's the quality? Does it radiate? What's the severity? And how long has the pain been there? Causes can be incidental, non-cyclic, episodic, during dressing changes, and continuous, for example, chronic pain. There are different types of pain scales used to measure pain. We sometimes use the 0 to 10 for verbal patients, critical care observation tool for sedated patients, pain assessment for the advanced dementia scale, which is PAIN-AD, the FLAC behavioral scale for 2 months to 7 years, the FLAC pain scale, the FACES pain scale for children 4 to 16 years, the Wong-Baker pain scale for adult and children greater than. It is very important to appropriately document the assessment of the wound. Documentation should include anatomical location, type of wound, tissue types and damage, measurements, staging if a pressure injury, any undermining or tunneling, describing wound edges and peri-wound, exudate type and amount, odor, if any signs of infection or pain, documenting the treatment plan, and documenting patient education. Let's look at the assessment documentation for our patient, Ms. Teresa Walker. We have the patient's complete medical history, any changes, her skin appearance, her activity level, her nutrition, her elimination status, her risk assessment, and documentation of the wound assessment. The next step in the nursing process after assessment is diagnosis. Assessment of the patient and wound helps to diagnose needs related to skin integrity, identifying treatment needs, and coordinating a treatment plan. The nursing diagnosis for Ms. Teresa Walker is altered skin integrity, as evidenced by stage 3 sacral pressure injury. Now let's move on to the actual wound care. After diagnosing, the next step in the nursing process is planning. Planning for wound care involves setting goals, setting objectives. The components of the planning would be the patient, the wound, and the treatment. Patient factors such as continence, activity, mental status, comorbidities, allergies, skin integrity, and compliance. Wound factors include type of wound, location, description, characteristics, and bacteria profile. Treatment factors include controlling odor and pain, adding or reducing moisture, combating infection, containing exudate, debriding, compress or manage pressure. After planning, the next step in the nursing process is implementation. This is where everything that was planned is implemented. Let's talk a little about dressings. What is a dressing? It's a protective covering placed over a wound. We have primary dressings and secondary dressings. Primary dressings are therapeutic and protective. The coverings applied directly over the wound. They either add, absorb, or maintain moisture, treat infection, or debride, which is removing devitalized tissue. Secondary dressings cover and protect the primary dressings. They can either maintain moisture, absorb, add moisture, and we can also use bandages, which are strips of cloth, gauze, or elasticized materials used to wrap a body part as our secondary dressing. Other wound dressing types include bandages, roller bandages, which have a circular turn, spiral turn, or figure 8. Binders, which are slings, abdominal binders, chest binders, or T-binders. Drainage systems can either be closed or open. Closed include Hemovacs, Jackson-Pratt, and Blake drains. The drainage tube is connected to a suction device, sutured to the skin, requires a clean procedure, and requires accurate measurements. Care includes emptying them and reestablishing suction. Open drains, such as the Penrose drain, are soft and flexible. The drainage is absorptive collection material, not sutured, and are secured with a sterile safety pin. It requires a sterile procedure to change dressings. Care includes preventing dislodging, sometimes shortened each day, and using sterile procedures to cut and secure. Additional therapies include fibrin sealants, made of fibrinogen thrombin, available in sponges, bandages, patches, and liquid glue. The glue is absorbed by the body eventually. Minimal drainage and scarring is left, and there's a decreased risk of hematomas and seromas. No dressing changes are required. Negative pressure wound therapy is a uniform negative pressure which causes mechanical tension on tissues, stimulating cell proliferation, blood flow, and growth of new blood cells, decreases bacteria and removes excess fluid, and provides a moist healing environment. And negative pressure wound therapy is used for acute or chronic wounds, wounds with heavy drainage, and slow healing wounds. Care. It has a foam interface covered with the hydrocolloid dressings called the tegaderm, and it's connected by a plastic tube to a suction device, usually changed 3 times a week. Hyperbaric oxygen therapy. It's a pressurized chamber with high concentration of oxygen to promote cell proliferation, healing, wound metabolism, increased response to growth factors, stimulates angiogenesis, antibacterial and antioxidant effects, and improved immune function. Heat and cold therapy. Heat therapy causes vasodilation. It dilates the peripheral blood vessels, accelerates inflammatory response to promote healing. It increases tissue metabolism, reduces blood viscosity, reduces muscle tension, joint stiffness, and pain. It's used to treat infections, increased cardiac output. Examples include hot water bags, electric heating pads, aquathermia pads, hot packs, warm moist compresses, sitz baths, and warm soaks. Cold therapy uses the technique of vasoconstriction. It constricts blood vessels, reduces muscle spasms, and promotes comfort. It reduces blood flow to tissues and decreases pain. Substances like histamine, serotonin, and bradykinin. Reduced edema, inflammation, and bleeding. Used for direct trauma, dental pain, muscle spasms, sprains, and chronic pain. Examples include ice packs, cold packs, and cold compresses. Very important cautions when using heat therapy or cold therapy include prolonged cold exposure can cause increased blood pressure, shivering, goosebumps, and tissue injury. Prolonged heat exposure, more than 20 to 30 minutes, leads to vasoconstriction. Surgical incisions, cautions and considerations. Incisions closed with primary intention usually have a sterile dressing for 48 hours. After 48 hours, incisions can be cleaned with a wound cleanser. The purpose of dressing is to absorb drainage, provide a sterile environment, and barrier to trauma. They can be left open when there is no drainage or chance of infection. Complications include infections, dehiscence, evisceration. Surgical incisions can be closed with either sutures, which is a common method of approximating skin edges, used for small incisions, absorbable or non-absorbable. In order to remove them, from the face is 3 days, arms and trunk, legs, scalp, 7 days, hands, feet, and over the joints, 10 to 14 days. Use the suture removal kit. It's a sterile procedure Steri strips can be used for additional support. Staples are another way of closing surgical incisions. These are used for larger incisions. For wounds that are straight, observable and non-observable staples can be used. The removal includes requiring special staple remover, removed in 10 to 14 days. Steri strips can be used for additional support. Ostomies. Surgically created diversions for feces, urine after partial or complete removal of intestine or bladder. They can be temporary or permanent. They are indicated for inflammatory bowel disease, trauma, bowel obstructions, and bowel perforations. 3 different types are ileostomy, colostomy, and an ileal conduit. The parts of an ostomy include the ostomy appliance, which includes a skin barrier or pouch to contain feces or urine. They can be in one-piece or two-piece systems. Accessories to promote comfort include skin barrier, paste, powder, barrier rings, wafers, strips, ostomy belts, binders, wraps, and swimwear. Care for ostomies includes emptying when 1/3 to 1/2 full and use the output spout. Changing appliances. Changing is done every 5 to 7 days using the clean technique. Now let's look at the planning and implementation for Ms. Teresa Walker. The goals: tissue repair and regeneration, restore skin integrity. Objectives: heal the wound in the shortest time possible with minimal pain, discomfort, and scarring to the patient. Components: the patient, Teresa Walker. Wound, stage 3 pressure injury. Treatment: wound care order from physician. Cleanse with wound cleanser and pad tray. Cover with calcium alginate. Cover with adherent foam dressing. Frequency 3 times a week. Patient factors: continence, activity, comorbidities, and skin integrity. Wound factors: type of wound, stage 3 pressure injury, location sacrum, description and characteristics: 4 centimeters by 3 centimeters by 0.2 centimeters, 85% granulation, 15% slough, scant serosanguinous drainage, no odor, peri-wound is macerated, no tunneling, undermining from 12 o'clock to 3 o'clock, max depth of 1 centimeter, pain 5/10, bacterial profile, no signs of infection noted, no redness, swelling, or increased drainage noted. Treatment factors: control odor and pain, add reduced moisture, contain exudate, manage pressure. The next step in the nursing process and the final step is evaluation. Evaluation is a continuous process that involves ongoing assessment and revised planning and implementation. Steps of evaluation include: reassess at regular intervals to monitor response to treatment, determine effectiveness of treatment, and make any necessary changes to the plan of care. The evaluation for Ms. Teresa Walker. Patient reassessed a week later. Per wound assessment, improvement to wound condition noted, decreased pain reported, and treatment is determined to be effective. Per the doctor, patient will continue current treatment plan and will be reassessed in 2 weeks.